Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture series, lecture number 75, that is the nutrition. This lecture contains including parenteral nutrition, nutrition requirements, malnutrition, assessment of the malnutrition, method of the feeding, internal nutrition and parenteral nutrition. All these points are covered in this lecture. Now start with the nutrition requirements. In day-to-day normal life, nutritional requirements is much lower than in post-operative cases and hypercatabolic states. A healthy adult easily requires 1500 to 2000 non-protein calories per day for energy. A healthy adult in normal state requires about 40 gram of protein or 6 gram of nitrogen per day. A negative balance of 10 gram of nitrogen in a day is equivalent to a loss of 63 gram of protein. Vitamins are necessary as supplement whatever may be the method of the feeding. Vitamins are essential for maintenance of the normal metabolic functions and these are not synthesized by the body. The water-soluble vitamins B and C help in collagen formation and wound healing in the post-operative period. The vitamin C requirement increases to 60 to 80 milligram per day. Dear students, here is a good picture for you showing the importance of the nutrition. Always use vegetables, fruits in your diet. Nutrition is the most important for your mental growth, for grasping the knowledge. Now the vitamin C is more depleted preoperatively if the patient was not on aspirin or by barbiturates therapy, or if he was suffering from the anorexia or in the habit of the excessive smoking. Vitamin B12 is depleted in Crohn's disease, ileal resections or bypass, blind loop syndrome, reduced pancreatic secretions, excess alcohol intake, anti-convulsant therapy after gastric surgery. Fat-soluble vitamins, that is the A, D, E, K, are depleted in steatorrhea, absence of the bile. Vitamin K is particularly given in case of the obstructive jaundice, where bile is not available for its absorption from the ileal and when there is a bleeding tendency. Now, the malnutrition. Malnutrition is not a common occurrence in surgery, though a few patients are seen to be suffering from the malnutrition either being present preoperatively or postoperatively or in certain hypercatabolic states. First, the preoperative malnutrition is often due to the starvation of the failure of digestion of the food before operation. Such malnutrition may develop in cases of poverty, cases of dysphagia, cases of excessive vomiting, cases of carcinoma of the stomach, pancreas, liver and biliary tracts, giving rise to the failure of the proper digestion and jaundice, cases of the blind loop syndrome in intestinal fistulas, the elderly and alcoholics who do not care to take the proper food. Post-operative malnutrition is quite common and occurs in all cases in transient form. And next is the hypercatabolic states. After severe trauma, extensive burns, severe sepsis, high fever and hypercatabolic renal failure, there is excessive calories utilization, and unless generous calorie intake is given, the body proceeds quickly to break down fat and muscle protein in the approximately equal proportion of the to provide the necessary calories for survival. Now the effects of the malnutrition are many of which defective wound healing, which may lead to wound dehiscence and leaking anastomosis of the bowel, are the main effect of the malnutrition. There may be increased susceptibility to infection, there may be reduced enzyme synthesis, defect in coagulation, decreased tolerance to radiotherapy, delayed callus formation in fracture and decreased tolerance to cytotoxic chemotherapy. Now the assessment of the malnutrition. Though approximate assessment of the amount of the deficient nutrition can be assessed by the nutrition can be provided accordingly. The estimate how much the nutrition has been given by the body weight, upper arm circumference, serum albumin estimation, nitrogen balance studies. First, the body weight. There is a list of the ideal body weight according to the height of the patient. By applying the body mass index, that is the BMI, which is equal to the weight divided by the height square in meter, equally weight in the kilogram and divided by the height square in meter, a man should have BMI ranging from 20 to 24 according to the structures. If the BMI is above the 24, then it is the obese patient. Second estimation is the upper arm circumference before and after the operation is a good indication of the amount of malnutrition or the negative nitrogen balance in the patient is having. Third is the serum albumin estimation should not be less than 33 gram per liter. Fourth is the nitrogen balance studies. Total nitrogen intake is compared with the loss from all sources, that is the nasogastric aspiration, fistula drainage, urine etc. Greater loss than intake indicates a negative balance and tissue breakdowns. More intake than loss means positive balance, which means anabolism and tissue synthesis. Now, the method of the feeding. There are two methods. One is the enteral nutrition and second is the parenteral nutrition. First, enteral nutrition by mouth, by tube and gastrostomy and jejunostomy. First, the by mouth. This is obviously the most convenient and effective route to provide nutrition. This being the physiological route, wherever the possible, this route should be chosen to provide nutrition. By tube, in the mouth feeding is not possible. A nasogastric tube is passed and nutrition is provided in liquid form through this tube. In case of the esophageal carcinoma, a special tube is in the form of the Sauter's tube and Celestine tube should be passed by endoscopy to provide the nutrition through this tube. Third is the gastrostomy. This is performed when the feeding cannot be provided mouth as well as the nasogastric tube, then gastrostomy should be done. Fourth is the jejunostomy. When the gastrostomy is not possible, there is due to the earlier gastrectomy or due to the carcinoma involving the stomach, then the tube jejunostomy is performed for feeding. Jejunostomy seems to be the more successful method of the feeding than gastrostomy. Now, the next method of the feeding is the parenteral nutrition. The indications for the parenteral nutrition is when enteral feeding is contraindicated and intravenous feeding becomes mandatory. Second indication is the fact when a severely ill patient is unable to take adequate oral nutrition either voluntarily or through a nasogastric tube. After 3 days, intravenous nutrition must be considered. Next indication is to restore losses that have already occurred and to arrest the catabolism, but preferably to prevent large losses by beginning treatment early enough and thereby restoring the internal environment towards the normalcy as soon as possible. Next indication is for the parenteral nutrition is the intravenous nutrition, therefore is not only concerned with the supply of the calories or nutrition, but also it provides with electrolyte equilibrium and maintenance of the serum oncotic pressure. Next indication is for the parenteral nutrition when there is a severe extrarenal loss of the protein, that is the ulcerative colitis or intestinal fistulae. Contraindications for the parenteral nutrition are these are severe hepatocellular damage, renal damage, congestive cardiac failure, uncontrolled diabetes and severe blood dyscrasis. Now, the other factors for the nutrition, among of that the carbohydrates first. The need for the carbohydrate in parenteral nutrition is too well known to require emphasis. Carbohydrates are the most readily available source from which necessary calories are derived. Because of the carbohydrate stores in the liver are rapidly utilized, calorie deprivation for more than the several hours lead invariably to the breakdown muscles protein unless carbohydrate calories are replaced. Next is the fructose is a better alternative since concentration up to 20% does not cause significant phlebitis, so a greater calorie intake can be obtained from the same fluid load. It is more rapidly metabolized in the liver than glucose and is less dependent on the insulin for its early metabolism. A further advantage of the fructose is that when used in combination with amino acids, the urinary losses of peptides are less than when glucose is used. And the next is the alcohol. The nitrogen sparing effects of the ethanol has been long known. In even low concentration, ethanol increases tissue oxygen intake, carbohydrate increases the oxidation rate of the alcohol, can also do amino acids. Ethanol is a useful calorie source providing 7.5 calorie per gram. It is not associated with urinary losses. It can be conveniently combined with the amino acid and fructose in the nutrient solutions. Next is the fat emulsion. Since fat has a calorie ratio twice that of the carbohydrate, so protein, it has taken many years to produce the reasonably safe fat emulsion suitable for intravenous use. Toxic reactions to intravenous for the fat emulsion are quite well known. The immediate reactions are pyrexia in the fat emulsions transfusion. Next is the amino acid solutions. Although the carbohydrates exhibit a protein sparing action, this is only partial in degree and fails to avoid the extensive loss of the lean muscles mass that may follow trauma, surgery, sepsis, burns or other serious illness. Therefore, essentially in parenteral nutrition to provide a nitrogen source in the form of the amino acids is physiologically balanced proportion. These are available either as a hydrolyzed amino acids derived from casein or as pure synthesized, that is the DL amino acids. Normally, only L amino acids are metabolized effectively for the maintenance of the nitrogen balance. Now the planning for the intravenous regimen is, it should be remembered that the energy from the carbohydrate sources should be provided not less than 30% of the total calories to ensure that there is a sufficient generation of the oxalic acetate by cycling the Krebs tricarboxylic acid cycles in the liver. If the patient has already hyperproteinemic edema at the start of an intravenous nutrition regimen, it is best corrected by the giving plasma or human plasma protein fraction, as it will take some days for new albumin synthesis from the intravenous amino acids. In long term intravenous nutrition regimen, 1 unit of the plasma per week is essential. Magnesium, potassium and vitamins will have to be added in case of the long intravenous regimen. Composition of the intravenous nutrition to be given per 24 hours. In first 8 hours, half liter of the amino salt 3.3%, fructose 15%, ethanol 2.5% plus 26 milliequilibrium KCl 2 gram, that is the 2 gram, half liter of the 20% of the interlipid and 5000 units of the heparin. In the second 8 hours, half liter of the 3.3 liters amino salt fructose, ethanol 2.5% plus 26 milliequilibrium KCl and half liter of the 10% of amino salt. And in the third 8 hours, half liters 3.3% amino salt, fructose 15%, ethanol 2.5% plus 26 milliequilibrium KCl and half liter of the 20% interlipid plus 5000 units in heparin. These are the planning for the intravenous regimen for the nutrition of the postoperative cases. This is the clearly showing the composition of the intravenous nutrition in 24 hours and first 8 hours, second 8 hours and third 8 hours. Dear students, here is the end of our surgery lecture number 75, that is the nutrition. Thank you.